Now, South Africa's COVID-19 mortality rate has been a subject of heated debate and much interest. The country has emerged from its first wave of infections with COVID-19 death rate roughly 7 times lower than many other countries across the globe. As of yesterday, the Health Department reported 174 more COVID-19 related deaths. To help us unpack what we're observing, let's bring in Vaccinologist at Wits University. That's Professor Shabir Madhi, who's also a member of the COVID-19 Ministerial Advisory Committee. Professor Madhi, thanks for always making time and welcome to the AM report. I remember for the longest time there had been these really grim predictions about how Africa, and South Africa in particular, should brace for one of the worst pandemics in the world. It's been a few weeks now and we simply haven't seen that happening. Are you at all surprised?
Good morning, Ayanda. And the short answer is yes, I'm completely surprised. And what happened in South Africa really requires further investigation. We've seen a huge number of people that have been infected, much more than the 650,000 that have been diagnosed. You probably could multiply that figure anything between 7 to 10-fold in terms of the true number of people that have been infected. But as you mentioned, despite that, we haven't seen much in the way of severe disease. And although people have died, the number of people that have died, even though the 13,000, 14,000 that is reported is probably an underestimate, still the number of people that have died is much lower than what was predicted at the onset of the pandemic. Now, the reasons for that, we're not too sure. Like I said, huge number of people have been infected in South Africa. One of the things that we're currently investigating is whether a high level of exposure to the common cold coronaviruses that have been circulating for a long time in humans since the 1960s, whether high exposure to those coronaviruses somehow is resulting in sort of cross-protective immunity, at least against severe illness from the SARS coronavirus 2. And for me, that is really the only way to try to explain this biological phenomena where despite high infections, that's not translating into severe disease, unlike what's occurred in high-income countries where much of that infection has actually translated into severe disease and death.
Right, and your choice of words is quite interesting there. High-income countries brings into the discussion the socio-economic element of how COVID-19 might work. I've read a few articles suggesting that because people in continents like Africa are so vastly dispersed in their communities or vastly spread, that also reduces the ability of not only passing on the disease, but potentially leading to severe illness if you do contract the virus. How much water does that line of thinking hold for you?
Well, I don't think that's the reason, because remember in South Africa, 60% of the population are living in urban areas. So it's actually the converse of that almost, in that when you're living in these highly densely populated areas, overcrowded areas, the transmission of these common cold coronaviruses probably is as efficient, if not more efficient than the SARS coronavirus. So it might be that people are being exposed much more in Africa, in a highly densely populated areas, to these common cold coronaviruses, and consequently are developing immunity from those common cold coronaviruses that is lending to itself to some protection against severe COVID-19. So it's actually in the rural areas, certainly what's happening is that because this is sparsely populated, there isn't a lot of people are not living very close together, the infection rate in the rural areas will be lower. And that obviously will result in less death as well. But in urban metros in Africa, these are highly densely populated areas, and that's the reason why we've seen such huge number of people in Soweto, as an example, that have been infected. But again, that hasn't translated into massive number of cases of severe disease or death. And I think there's something else in terms of their immunity, which is assisting them in terms of mitigating the progression of that viral infection.
And what would we have to do to explore that hypothesis further, Prof? Is it a matter of, again, mass testing for this form of immunity that you're alluding to, or I guess waiting until we get to a point where things reveal themselves as we continue trying to carve out this new normal?
Yeah, so what we need to do is we actually need to go back to historical samples, which is what we're doing currently. Samples that we collected from before 2020, 2019 and earlier, to see what percentage of the population have got this, what we call T cells, that show cross-reactivity against the SARS coronavirus 2. So those are the experiments that we're currently embarking on to see what percentage of the population historically have already got some level of immunity against what would be SARS coronavirus 2.
There's no debate, I guess, that this is relatively good news for a country like South Africa, but I don't imagine it suggests that we're out of the woods just yet, or does it?
No, certainly not. I think we're still not out of the woods, and in my opinion, I think we're still going to experience a second wave. But that second wave most likely is going to be much less severe than the current wave, which itself has been fairly modest, and we probably will see a fewer number of severe cases, a fewer number of hospitalizations. So we're still likely to see a second wave over the next few months. There's a number of factors at play which influences when the second wave might arise, but I don't think it's going to be anywhere close as severe as what it was this time around, which, like I said, itself was probably less severe than what had been predicted for South Africa.
One of the hypotheses, Prof, that are being brought forward is that South Africa is not seeing the worst fallout of COVID-19 because of our reaction at the beginning stages of the outbreak. You, if my memory serves me well, were one of the people who actually spoken out quite strongly against a hard lockdown like ours that lasted for as long as it did. Are you starting to perhaps revise that position, considering that it too may have contributed to these promising trends, if you like?
No, certainly not. I think that's a complete misrepresentation in terms of what lockdown achieved. Like I said, if the lockdown was successful in terms of containing the spread of the virus, we wouldn't have seen the number of infections that have occurred in South Africa. And again, I need to emphasize that in a place such as Soweto, and we're doing the studies currently, but just based on our empirical evidence, the number of people that have been infected in Soweto, the percentage of the adult population that's been infected is anything between 30 to 40%. And if the lockdown was successful, we certainly wouldn't have had that sort of infection rate. So the type of amount of infection that's occurred far exceeds what would have, had the lockdown been successful, we wouldn't have seen such a high percentage of the population being infected. The reason why we've come out of this relatively well positioned, again, like I said, is probably unexplained, but in my mind, I think it's related to this underlying immunity, which somehow has assisted in terms of protecting against COVID-19, but it's got very little about a lockdown. Okay. The only thing the lockdown probably was to buy us some time. We also have facilities to better equip themselves.
But Prof, surely we can also make the argument that because we're able to buy time, we're able to better prepare so that we can treat those with severe illness, and that in turn has contributed to a decreased mortality rate.
No, certainly not. And the reason for it, we've been highly fortunate. The reason for that is we haven't seen our health facilities being completely overwhelmed. So the additional field hospitals that were set up as an example, the occupancy at Newzroom as an example, has been 100, 200 individuals. So we couldn't second guess what was going to happen. So it was necessary to do that. But that is not the explanation for what we call a low mortality rate in South Africa, which in fact is also incorrect. Because when we talk of case fatality risk, which is what is the figure that's usually cited, 1.5%. And when we make comparisons to high-income countries that calculate the case fatality risk in a very different manner, that's a complete misrepresentation in terms of what the case fatality risk actually means. So in South Africa, when we're calculating case fatality risk, as part of that denominator, we're including everyone that's being diagnosed, including in community. In high-income countries, in the United Kingdom, in Spain, in Italy, when they were calculating the case fatality risk when they had the first wave, it was based on a number of people that were hospitalized, and that was 12 to 14%. If South Africa calculates its case fatality risk based on the number of people that are hospitalized, it's exactly the same as what it was in the United Kingdom and in Spain. So the way you calculate the case fatality risk influences what sort of number you get. At the end of the day, with SARS coronavirus 2, irrespective of where in the world you are, your recovery rate is going to be more than 95% to start off with. Because remember, 60% of people that are infected are completely asymptomatic, which means they've recovered. And of the people asymptomatic, 85% will have a mild illness, and they will recover irrespective of what happens. They don't go to the hospital to get management or treatment, so they recover. So your recovery rate for SARS coronavirus 2 by default is already 95%. So when we sort of going onto the mountains and screaming success because we've had a 90% recovery rate, it really means very little. It's all about the number of people that died per thousand of the population or per million of the population, which is much more important. In South Africa, that number is low. But like I said, the reason that number is low is not because of what our healthcare services has achieved, but rather because something else which is underpinning why people have not progressed to severe disease despite them being infected.
It's very interesting indeed. Whatever the reason is, the need for a vaccine, I think, still remains quite an urgent one nonetheless. Take us through, I guess, some of the progress you've been able to make, because I do know that you're also leading a team of experts to try to develop a vaccine here in South Africa.
So currently we're investigating two different vaccines. The one is what we call a non-replicating viral vaccine. The other one is a protein-based vaccine. And for both the first study, we almost have enrolled the complete complement of 2,000 participants. And as you know, these individuals are randomly assigned either to receive the vaccine or a placebo. And then we follow them up until we get about 42 cases of COVID-19. Paradoxically, because of the waning of the outbreak in South Africa, we probably now will be delayed in terms of when we get an answer as to whether the vaccine actually protects against COVID-19, because it's going to take us much longer for at least 42 individuals participating in the study to eventually develop COVID-19. In the second study, again, a similar sort of a design where we're targeting enrolling just under 3,000 participants. And in that study, we're currently enrolling across the country in the Western Cape, in KwaZulu-Natal, in Gauteng, as well as in the Free State.
All right.
So with all of these studies, I think we probably will hopefully get an answer in South Africa by the first quarter of next year. But it might be that together with the other studies that have been conducted, at least for the first vaccine, together with Brazil and the United Kingdom, we might be able to get an answer this year already by combining the information to see whether the vaccine actually protects against COVID-19.
Professor Shabir Madhi, always great getting your insights. Thanks once again for making time for the AM report. Professor Madhi is a vaccinologist with Wits University and is also a member of the Coronavirus Ministerial Advisory Committee. Really interesting insights this morning.